Medical algorithms exist to standardize care. We rely on them to create predictability in emergency rooms. But when human physiology is pushed to its extreme limits by severe soft tissue trauma, these protocols begin to fracture. Rigid adherence to standard algorithms becomes a primary driver of preventable mortality. We refer to this gap as a Traught variance, the lethal discrepancy between what a hospital protocol dictates and what real-time physiological deterioration actually demands. The most immediate example of this variance occurs in the thermal airway. A patient exposed to a flash fire presents with distinct physical markers: facial burns, carbonaceous sputum, and early supraglottic edema. These are the physical signatures of thermal energy inhaled directly into the respiratory tract. Standard respiratory distress protocols often advise waiting for laboratory confirmation, checking arterial blood gas values or oxygen saturation drops before committing to a ventilator. In a thermal injury, explosive airway edema is completely nonlinear. The tissue swelling accelerates exponentially as fluid leaks into the damaged mucosa. If you wait for the blood gas values to confirm hypoxia, the vocal cords will have already swollen shut. You lose the airway entirely. Securing a thermal airway requires a clinical decision based entirely on the mechanism of injury. If physical triggers are present, clinicians must intubate before airway edema makes the procedure anatomically impossible. Once the airway is secured, the physiological crisis shifts to intravascular volume. To replace the massive fluid loss from capillary leak, we calculate the Parkland formula: 4 milliliters of lactated ringers multiplied by the patient's weight in kilograms multiplied by the total body surface area burned. This maps the formula using the rule of nines. The vascular system rapidly sequesters fluid into third spaces. You must administer 50% of this fluid in 8 hours, starting at T0, the thermal spark. Arriving 3 hours late compresses this into a 5-hour window. Failing to recognize this compressed timeline leads directly to under-resuscitation. The kidneys shut down, the cardiovascular system collapses, and systemic shock sets in. This graph charts predicted Parkland fluid volumes against real-time urine output. While the theoretical calculation remains flat, actual urine output dips sharply. When urine output falls below 0.5 milliliters per kilogram per hour, the protocol is irrelevant. You must immediately step up the infusion rate. Continuous end-organ perfusion is the ultimate arbiter of resuscitation. Physiological output continuously overrides the mathematical prediction. Pushing massive volumes of fluid to maintain perfusion creates a secondary mechanical crisis. As tissue absorbs the fluid, circumferential ischemia becomes an immediate threat. This anatomical cross-section isolates the outer boundaries of the skin, the epidermis and the underlying dermis. Full-thickness burns destroy the elasticity of these layers, creating a rigid, leather-like shell called an eschar. As the aggressive fluid resuscitation causes underlying capillary leak, the expanding edema hits this hardened barrier. The skin itself acts as a mechanical tourniquet. Resolving this requires an immediate bedside escharotomy. The physician physically slices through the burnt epidermis and dermis, releasing the external tension and restoring blood flow. But we must distinguish superficial restriction from a much deeper pathology, internal compartment syndrome. Here, the focus shifts entirely to the subcutaneous fat, the deep fascia, and the muscle belly. In blunt force trauma or severe crush injuries, the swelling originates deep within the muscle. The expanding tissue is trapped beneath the unyielding layer of deep fascia. Consider a patient with a cold, pulseless hand. An intracompartmental pressure monitor is inserted, reading 45 millimeters of mercury. This gauge calculates the exact physiological tipping point, known as delta P. We take the patient's diastolic blood pressure and subtract the measured compartment pressure. This equation determines the absolute state of tissue ischemia. When the delta P gap drops to 30 millimeters of mercury or below, arterial capillary beds collapse. A bedside escharotomy will fail here because the restriction is under the deep fascia. The patient requires emergent transport to the operating room for a surgical fasciotomy to slice through the fascial envelope and salvage the dying muscle. External mechanical tourniquets require superficial release at the bedside. Internal fascial expansion mandates deep operative intervention. Mechanical ischemia destroys tissue through physical pressure. Necrotizing soft tissue infections, specifically those caused by Vibrio vulnificus, destroy it through rapid biological invasion. In its earliest hours, the infection presents with mild erythema and localized swelling. It perfectly mimics benign, routine cellulitis, effectively camouflaging its severity. While the surface appears stable, the bacteria execute a rapid horizontal spread along the deep fascial planes, liquidating tissue completely out of sight. The clinical hallmarks of this process are extreme: pain that is completely out of proportion to the physical exam, paired with the sudden onset of systemic toxic shock. This clinical case details a patient presenting with fever, profound hypotension, and dark hemorrhagic bullae on the lower leg following a seemingly minor cut sustained in salt water. Faced with these severe symptoms, the algorithmic trap is the instinct to delay treatment while waiting for diagnostic certainty, ordering an MRI, or waiting for lab results to calculate the LRINE score. The LRINE score uses standard blood work to calculate the probability of necrotizing fasciitis, but up to 10% of patients with active, flesh-destroying infections will score under a 6. The test can leave a deadly false negative. Radiographic imaging is another common delay. This lateral foot radiograph shows the classic indicator of advanced tissue necrosis, air trapped within the soft tissues. Subcutaneous gas is highly specific to necrotizing infections. When you see it, the diagnosis is confirmed, but it is dangerously insensitive. Many lethal strains of bacteria do not produce gas at all. A patient with rapidly spreading erythema and excruciating pain, who returns a completely clear X-ray with zero evidence of gas, is still at imminent risk of death. The physiological response is absolute. You override the lab score, abandon the MRI, and immediately escalate to surgical exploration. In necrotizing soft tissue infections, the diagnosis and the treatment are the exact same maneuver: aggressive surgical debridement down to healthy tissue. A consistent pattern emerges across thermal burns, mechanical crush injuries, and rapid infections. Standard hospital protocols frequently lack the precision to account for the rapid physiological shifts characteristic of high-acuity soft tissue trauma. This decision matrix plots standard protocols against physiological reality. Variance 1. Calculating Parkland fluid from ER arrival pauses under resuscitation. Variance 2. Waiting for lap drops ensures a total loss of the airway. Variance 3. For deep compartment syndrome, elevation is dangerous. Raising the limb mechanically drops arterial inflow pressure, starving the muscle of limited oxygen. Variance 4 is the infection trap. Delaying the debridement of suspected gas gangrene to obtain an MRI allows the bacteria to outpace the surgical intervention. These 4 fatal exceptions all share a root cause: prioritizing a standardized protocol over the immediate reality of physiological deterioration. To understand how these rules conflict in real time, examine a severe blast injury, an event that combines third-degree thermal burns with massive blunt force crush trauma. The physics of the blast deliver both a thermal flash that decimates the skin layer and a kinetic shockwave that crushes the deep muscle compartments. This forces a direct clinical contradiction. You must push massive volumes of fluid to treat the burn shock, but that very fluid will rapidly inflate the internal compartment pressures from the crush injury. This dual-axis visualization tracks the dilemma. Pumping lactated ringers into the system fulfills the burn requirement, but simultaneously drives the internal delta P straight toward the critical 30 mm threshold of ischemia. Managing complex trauma requires continuous reassessment of active physiological data. Survival in these cases depends on adjusting tear based on urine output and delta P measurements, even when those adjustments contradict the initial protocol.